Factors impacting maternal and women's health. Family changes in parental roles. We know now that the parental role has evolved over time due to social and economic changes as well as family changes. The traditional role of the father being the provider, the mother being the nurturing homekeeper. The roles have kind of gotten blurred. We now have more women in the workforce. We have stay-at-home dads, or we have both families that work, both parents that work full-time. So the different changes in parental roles have definitely changed over time. I want you guys to be familiar with Table 1.1 on page 16. It gives examples of the family structures in today's society. So you need to know the different types of families, such as the nuclear family, single parent family, your step or blended family, extended families, LGBT families. So kind of know the general definition of the different types of family structures, because in maternal, newborn, and fetal health, you will see all of these different types of family structures when you're taking care of a patient. Genetics. Genetics is the study of heredity and its variations. It has implications for all stages of life and all types of diseases. We're going to talk about a little bit about gender and race and how those things impact women's health. So gender is established when the sex chromosomes join. We know that XX gives us a female, XY gives us a male. Then race. Race refers to the physical features that distinguish members of a particular group, such as skin color, bone structure, or blood type. So public awareness is important in educating couples at genetic risk about the benefits of screening programs. And we'll talk more about this in later chapters. We know that some genetic disorders are based on race. We know we have sickle cell anemia, which is I don't want to say popular, but it's more prevalent in your African Americans. Scoliosis you see more in females versus males. So things like that. Also, society has a major impact on the health of women and their families. Major influences include social roles, socioeconomic status, the media, and the expanding global nature of society. Each of these can influence a person's self-concept, where he or she lives, the lifestyle he or she leads, and thus their health. This kind of goes back to the previous slide, where we know that genetics is the study of heredity. Gender determination is influenced on the physical characteristics, personal attributes, and behaviors. We know that some diseases are more prevalent in a specific gender, which I talked about on the last slide. Race is biologic differences in members of a particular group. Some variations are normal in a race but considered a disorder characteristics in other races. So we know that some diseases are based on race alone, like we talked about in the previous slide. I want you guys to be familiar with Table 1.2, that's on page 23. It talks about beliefs and practices of selected cultural groups. So it goes over a few things about the African American culture group, Asian, Arab Americans, and Hispanic Americans. And then if you turn over, it also talks a little bit about Native Americans. So I want you to be familiar with those different culture groups and some of their beliefs. When we talk about nutrition we know provides the body with calories and nutrients required to sustain life and promote growth. And we know pregnancy is a time when a woman needs to she needs to have inadequate nutritional intake, because not only is she eating for herself, but as we commonly say, she's eating for two, but she has to have enough stores where the baby can survive off her stores, and then without depleting her stores, she can survive off whatever's left, because the baby is going to take what it needs. So at no other time of life is nutrition more important than during fetal development and infancy. Adequate nutrition is essential for tissue formation, neurologic development, bone growth, and overall long-term health. And we'll talk about nutrition in pregnancy in a later chapter. Talking about lifestyle choices, we want our pregnant women, or our women who are of childbearing age who are trying to become pregnant, we want them to make good lifestyle choices. We usually tell moms no smoking, no drinking alcohol, things like that. Learn to cope with the stress, because we know that stress can have can cause untoward events in the body. So we definitely want them to make good lifestyle choices. Environmental exposure. Pregnant women are exposed to many and varied environmental chemicals. Scientific evidence documents that widespread exposure to environmental chemicals at levels that are encountered in daily life can have an adverse impact on reproductive and developmental health. Usually with our pregnant women, we want to make sure that they're not exposed to any type, we call them teratogens or teratogen. These are things that could be harmful to the developing fetus. And we'll talk about teratogens also. Stress and coping. Definitely we want women to eliminate stress or reduce stress in their life. And if you remember back to the video, the infant mortality video that I had you guys look at, one of the main reasons that they were saying the preterm labor in that town was a lot of the stress of living in poor socioeconomic status, things like that. So stress and coping. Stress definitely plays an effect on women's health while they're pregnant. Continuing with factors that impact maternal and women's health, we know that healthcare costs are skyrocketing. Very few people can actually afford to pay the insurance premiums. We have a lot of people in our country that may not have health care, and that can also be a barrier to getting prenatal care, a fear of the cost that's going to be associated with it. Our access to health care is the lack of insurance, which is a major deterrent for people for seeking health care. One thing I like to tell my patients is, when you become pregnant, and if you can't afford health care, you can apply for pregnancy Medicaid, and they will pay for your visits, your prenatal visits. Usually they pay for 13 if it's a normal risk pregnancy, and they will pay for the up to your 6-week visit. And then if you still don't have insurance, the baby can get the Medicaid also. Talking about preventative care focus, where the emphasis is on reducing costs, and if we can catch certain diseases and disorders before a person gets it, it will help reduce healthcare costs in the later on. Continuum of care is cost effective and provides efficient and effective services. This continuum extends from acute care settings such as hospitals to outpatient settings, primary care clinic, doctor's office, rehab units, things like that. So these are all things to help control or contain the skyrocketing cost of health care. Because of tremendous improvements that have been made in technology and biomedicine, disorders and diseases are being diagnosed and treated earlier. We have a lot of screening tools that we can use. For example, my women, your mammograms, your pap smears, things like that, to prevent breast cancer or cervical cancer. Question: is the following statement true or false? The definition of family and its structure has remained fairly constant over the years. True or false? The answer is false. The definition of family has changed over time as has the typical family structure, such that the traditional nuclear family is no longer considered the dominant family structure in today's society. Social roles. Social roles, society often prescribes specific patterns of behaviors. Certain behaviors are permitted and others are prohibited. These social roles are often an important factor in the development of self-concept. Social roles influence a person's idea about him or herself, and social roles are generally carried out in groups with which the individual has intimate daily contact, such as the family, school, workplace, or peer group. So these all kind of help in the development of a person's self-concept. The socioeconomic status is another dominant influence on health. Typically, your people who are of lower socioeconomic status, those that are poverty-stricken or homeless, typically they have worse health outcomes, and they're typically the ones that are not receiving health care benefits or seeing health care providers. Violence or domestic violence, we're going to talk about that in a later chapter, so I don't want to go too much into that. Community, the schools, peer groups, neighborhood connectedness, this all plays a role in the shaping of a person. And last but not least, global health for women. With the invention of airplanes, the internet, we have become more of a global society. We can reach all different parts of the world now without ever having to step foot in that country. And we have a lot of doctors who will do consults over the internet from other countries. So we're definitely experiencing this global health atmosphere in our country, where we're no longer just only what's done in the US. We have doctors who will get on the internet or get over, some type of Wi-Fi or a conference video call and can actually prescribe and give healthcare advice. So definitely we are seeing more of this global health in today's healthcare arena. This is box 1.3 on page 21 in your textbook, and it goes over the acronym RADAR. We use this when we suspect abuse. Routinely, we screen every client for abuse, even if they're pregnant or not pregnant. Even when you're in the hospital in a med-surg unit, we ask people if they feel safe in their home. Have they been abused physically, mentally, verbally, financially? So we have this. So R, routinely screen every client for abuse. A, affirm feelings and assess abuse. D, document your findings. A, assess for your client's safety. And R, review options and make referrals. And it is a joint commission standard that we routinely ask everyone about abuse. We're still talking about factors that impact maternal and women's health. We've kind of talked about this. Developmental level and disease distribution is variable with age. Nutrition, they can be deficient or be excess, and we know that obesity is running rampant in our country. Lifestyle choices are, do you exercise? Are you a couch potato? Do you smoke? Do you drink? Do you do drugs? All of these things we want to identify in our patients, especially those who are trying to become pregnant. We want to ask about environmental exposure. One of the main women that are at risk are your nurses, because we are around radiation. If you're on a cancer floor, you're around chemotherapy. You're around different body fluids. So, those are environmental exposures. Stress and coping, exposure to traumatic events, crises, inadequate support systems, and violence. And like I said earlier, stress is a major cause of preterm labor and sometimes preterm delivery. Healthcare cost containment, quality of care maintenance while attempting to reduce healthcare costs, shorter hospital stays. It used to be when you had a baby, you were in the hospital for up to a week. Now with a vaginal delivery, 24 hours is the minimum stay required, and for a C-section, 48 hours. So that's 2 days. Healthcare costs, so there's an increased awareness of costs and supplies and services, and like we were talking about earlier, I told you guys the hospital is a business, and as a nurse you have to be very cognizant of your usage of supplies. So you can't take the whole bucket into the room, because once it's in the room it belongs to the patient. So we're very cognizant of cost while we're working. Access to healthcare, provision of healthcare within a limited resource environment, and access to services, healthcare insurance, and reimbursement. Reimbursement typically is pretty good with your maternal things. Most insurance companies, they follow Medicaid and Medicare. So like I said, Medicaid will pay for 13 prenatal visits as long as the mom is, low to medium risk. And so most insurance companies, they follow that. So we'll talk about how we space our prenatal visits a little later on. When we're talking about preventative care, we want to focus on anticipatory guidance and education. So before a person becomes a disease, we want to do a lot of teaching to help prevent that disease. So like our patients who may become diabetic, before they actually become diabetic, we talk about lifestyle changes such as exercise, eating better, losing weight, things like that. The continuum of care focus, it provides for more efficient and effective services in the healthcare arena. So my factors impacting maternal and women's healthcare: empowerment of healthcare consumers. There is an increase in responsibility by individuals and families for their own health. So we're actually wanting patients and their family members to become more involved in their own health care. There's a family desire for information and participation in decision-making process. We like to include, other family members, spouses, kids, things like that. And as healthcare providers, we should respect the family's views and concerns. We should address their issues and concerns. We need to have high regard for the client, their partner, and parents as important participants in their healthcare experience. All right, here's another question. Which of the following is a cost-effective strategy to provide more efficient and effective services to clients extending from acute care to outpatient settings? A, cost containment; B, continuum of care; C, consumer empowerment; or D, preventative care. The answer is B, the continuum of care. And I'll leave that up there for a minute so you can read the rationale. Okay, now we're going to talk about some barriers to healthcare. We've already kind of hit on some of these, but these are things that you will definitely see working in the healthcare environment. Finances, limited or no health insurance, poverty-stricken patients. You see this day in and day out. I have taken care of many homeless, pregnant women, and it's so odd to say, well, when I'm discharging her, do I discharge her to home? Well, she doesn't have a home. Do I discharge her to the park across the street? So it gets kind of iffy, but the good thing in healthcare is we have other members on our interdisciplinary team, and that's when I elicit the help of my social worker Can you please help me find housing or temporary housing for this patient? Transportation is another barrier to health care. So the lack of a car, inability to use public transportation, needing to bring small children along on a visit. A lot of your doctor's offices don't allow children to come. And sometimes when you come to the hospital, if they have to come to the hospital to be seen, uh, a lot of the times, many hospitals don't allow their kids to go into the triage area. So I've had moms where I've had to put in private rooms because I couldn't put them in triage, and they had no one to come pick up their other children. Um, with the transportation, I tell moms as part of Medicaid, their Medicaid things, they have access to a Medicaid cap that will take them to and from their prenatal visits. So they can't use, oh, I don't have a car, I can't make it to my doctor's visits, because Medicaid will actually pay a cab to take them to and from their doctor's appointments. Language and culture. Difficulties in communicating information, beliefs related to some forms of treatment. We definitely see this. We're in Florida. We are kind of like a melting pot. I've taken care of many patients who I didn't speak their language. Thank God for the translation phones, or people in the hospital who may speak their language that are on the translation team. So, but all of those can be barriers to healthcare. The healthcare delivery system itself, we're seeing earlier and earlier discharges, possible limits for specialty care. If you ever heard of DRGs, oh, she's in there for vaginal delivery, 48 hours. If she's not well enough to go home, we need to talk about something else, but we give you 48 hours. So that's where the social worker comes in, and the doctors, they sit and discuss, like, what's going on with her care. They're not covering after this certain hour. Is she well enough to go home? Can we send her home with some home health? So all of these things. Clinic hours, a lot of people work. And usually most doctors' offices close at 5. They're not open on the weekend. And some women have a hard time, if they work, of getting time off to come to doctor's visits. Negative attitudes toward poor or cultural diverse families by some healthcare providers. I hate to say this, but you do have some health providers that, may talk down or degrade people because they may not speak the language, they may not be the same race or ethnicity as they are. So, that would be a barrier. Who wants to go to a doctor who's mean to them, or who, degrades them? Some legal and ethical issues in maternal and women's health care. In maternity nursing, the ethical principles of beneficence and autonomy provide the fundamental framework that guides the management of all pregnant women. Because the fetus also needs to be considered, autonomy can become a complex issue, giving rise to what is sometimes called maternal-fetal conflict. Fetal care becomes problematic when what is required to benefit one member of the dyad will cause unacceptable harm to the other. Even when a fetal condition poses no health threat to the mother, caring for the fetal client will always carry some degree of risk to the mother without direct therapeutic benefit for her. So some of the legal and ethical issues you'll see in maternal health is abortion. We know abortion is legal, but it has a lot of social and political stigmas. Many nurses have to struggle with their personal beliefs and their professional duty to take care of the patient. Substance abuse, fetal injury if the woman is pregnant, possible charges of negligence and child endangerment. So it's been kind of brought up Well, if a mom tests positive and the baby's positive, should we sentence her to jail? And a lot of people look negatively upon that because we know that substance abuse is a disease, it's a disorder. So should we put them in jail or should we put them in treatment? And you're going to get a lot of send them to jail, they're harming their baby. You're going to get, no, it's a disease, they can't help it, they need some help. So it goes back and forth, back and forth. So everyone has their own specific belief. Intrauterine therapy, medical technology versus nature, better quality of life by a surgical intervention. We have so much technology in maternal and fetal health care. It gets to the point you can pick the gender. They have it where you can pick the eye color of your baby, things like that. So a lot of that is very controversial. And we already talked about the maternal fetal conflict. Stem cell research. This is also an ethical legal issue and very controversial in maternal health. The goal of stem cell research is the relief of human suffering, which ethically is good. Benefits of stem cell research include providing therapies for Parkinson's disease, regenerating diseased body tissues, replacing spinal cord injuries, and growing needed organs for transplant. Now, the controversy focuses on the use of embryonic stem cells because the process of obtaining these cells results in the destruction of the embryo. Some people feel that the destruction of the human embryo constitutes the killing of a human being and reject this practice on religious grounds. Umbilical cord blood banking is a vast source of primitive hematopoietic stem and progenitor cells available for clinical application. And I've had quite a few families that have done the umbilical cord blood banking. And that's been around for years. Informed consent. The purpose of informed consent in healthcare is to ensure that client autonomy is respected in decisions about their health care. It is an agreement by a client to undergo an operation or medical treatment or take part in a clinical trial after being informed of and understanding the risk involved. It is a legal document in all 50 states and stems from the legal and ethical right an individual has to decide what is done to his or her body, and from the physician's ethical duty to make sure that individuals are involved in decisions about their own health care. This is box 1-4 on page 31. It talks about the key elements of informed consent, and I know you guys have heard this before. The decision maker must be of legal age in the state with full civil rights and must be competent to make informed consent or give consent. The information is presented in a manner that is simple, concise, and appropriate to the level of education and language of the individual responsible for making the decision. The decision must be voluntary, without coercion or force or under duress. There must be a witness to the process of informed consent. That's usually the nurse. We witness it. And the witness must sign the consent form. I know you all know about HIPAA, so I'm not going to spend a lot of time on it. But HIPAA, it has to do with patient confidentiality. It was instituted in 1996. The confidentiality of healthcare information is now mandated by law. The primary intent of the law is to protect health insurance coverage for workers and their families when they change or lose jobs. Another aspect of the law requires the United States Department of Health and Human Services to establish national standards for electronic transmission of health information. The HIPAA regulations were instituted to protect the privacy of individuals by safeguarding individually identifiable healthcare records, including those housed in electronic media. So we all know HIPAA. You can only look at a patient's chart if you have direct care with that patient. You can't even look at your own chart. You have to go through medical records to look at your own chart. We know you can actually be fired if you're working and let's say you had labs done at the hospital you work at, and you go, oh, I'm just going to look up my labs, or I'm going to look up my mom's labs. Everything in the computer is trackable, and let me tell you, they will call you and find you. I had a student whose last name was Jackson, and the patient that was assigned to him, her last name was Jackson. So I did, as the instructor, get a call, and I had to say, no, this was a student. He wasn't doing anything that he wasn't supposed to do. This was a patient that was assigned to them. The patient just so happened to have the same last name, so they do follow up. Now, what are some of the implications for nurses when we're talking about maternal and newborn and women's health care? So the nurse should be proactive in advocating and empowering her clients or his clients. There needs to be a need for solid knowledge base about factors impacting health and barriers to health care. There needs to be anticipatory guidance. We do a lot of teaching in nurses. The nurse needs to work within the framework of the nursing process. Everybody should know 80PI. There needs to be an alert to new technologies and treatments. Never think that just because you graduate, your learning has ended. This is when it starts. As nurses, we continuously have to stay abreast of all the new technologies and treatments. Medicine changes very fast, so you have to keep up with it. And then we need to integrate evidence-based interventions, evidence-based practice when we care for our women and neonates. This is the end of Chapters 1 audio lecture. Thank you.